I'm Dr. Jim Del Rosso, a dermatologist in Las Vegas, Nevada, and your host for Tea with Dr. D. And I am extremely happy, very excited about this episode because we have someone joining us today who I've known for quite a while. He's a good personal friend, but a tremendous colleague, a great dermatologist, a great teacher, a great clinician overall in dermatology, and really very advanced in aesthetic and cosmetic dermatology. And that's my good friend, Dr. Gary Goldenberg, who practices in New York City and is also on faculty at Mount Sinai in New York, where he was previously full-time, and now he's had a private practice for some time with his wife, who's also a dermatologist and a great lady. But Gary, toasting to you, and even got specially for you some lemon ginger tea with probiotics. So it's great to have you here today with Tea with Dr. D. Thanks.
Thank you so much for your kind invitation. I'm always excited to talk to you on or off camera, and I'm looking forward to our discussion. Thank you.
So I'm looking at your dermatology history, which could take up the entire time. But you were born in the Soviet Union and you came over when you were 13 years of age, and we're very glad you did because you've done so much in dermatology as well as being a great friend. So medical school at Temple University in Philadelphia. Then you went south for your derm residency at Wake Forest, where you were with people like Joe Urizo and Gil Yosipovich and Amy McMichael and Steve Feldman. The
Special
list
group.
goes on and on. It's very,
Yeah,
very special group,
special group.
right? And then you went to do Derm Path out west. So there you are at Temple in Philly, rough neighborhood.
Go
And then you're
Birds.
going down to Wake Forest, down south. Then you go out west to the Rockies, University of Colorado, and did dermatology and Derm Path. University of Maryland, where you did dermatology and was director of dermatopathology. So back sort of in the middle of the East Coast. Then you go to New York, in the heart of it, with Mark Lebwall and the others at Mount Sinai, where you were director of the faculty
Faculty
practice or something
practice.
like that, and you were doing derm path and general dermatology. And then Gary said to his wife Christina, who's also a dermatologist, medical and cosmetic dermatology, we're going to go to the Upper East Side, kind of like the Jeffersons did years ago. So you were moving on up, and since 2017 you are running and managing your own private practice. So what was that transition like after all these ultra academic places?
Look, I've been very lucky in that I've been surrounded by really terrific people from, not just medical school, but really in residency, who really showed me the way to do medicine, the right way. From Wake to Colorado, and then working with Mark Lebwall, who's our mutual friend. He's the best. He's a mensch. So I was very, very lucky to do that. And I think at one point I just decided that I wanted to do it on my own. So that was the transition. It was not, I wouldn't say it was very difficult, but I wouldn't say it was very easy either. Like any transition, there were some stressors that came with it. And look, there's stressors of being in academic practice, and there are also stressors of being in private practice. I consider myself very fortunate. I have a great patient base that I take care of. A lot of my patients are my friends. I love talking to
Your
them,
partner's
taking
pretty
care
good
of
too,
them.
right?
Yeah, my
Your par-
partner, it's great because I have the same boss at home and in the office, so it makes I don't have to
Consistency,
think
right?
about where I am. So that does make it easy. But it's great to be a dermatologist. I love being a doctor, and I've done a lot of different things, and I've really enjoyed them. So I'm very happy. I'm really blessed. It's been a blessing.
So before we get into the actual topics that we want you to talk about and show some very instructive videos, was there ever a time that felt like a right time, like this is going to be easier now, or you just decide for anyone thinking about it that they're going to leave a comfortable place where they're part of a big institution or a group, but now they're going to go on their own? When did it feel right, or did you just have to decide now I'm going to do it?
I think if you start thinking about it, you're going to do it. So if that, the way I always think about, life decisions, once that thought enters your mind, it's inevitably going to happen unless the list of pros and cons is so much further for the cons of leaving or moving. But I think, I have an entrepreneurial spirit, I think, even when I was in academic medicine. And I think being able to do something on my own with a partner, and look, I got a lot of support from Mark and Mount Sinai. I still do, as you know. I think, building relationships with patients and referring doctors, once you have those established, I think if you want to move, I think it's possible. It's not easy, but I think it's very rewarding once you've done it, and look, I'm lucky because I'm still involved with Mount Sinai very much. I'm still involved with academic medicine in a way of lecturing and being at meetings, exchanging ideas, running clinical trials, etc. So for me, I think it was the right time, and it was a good transition. And I would encourage people, if they want to take the plunge, I'd encourage them to think about it and have a plan and then do it.
Sounds great. So, Gary, one of the reasons why I reached out to you, and here's a toast to you and the
Thank you.
success that you've had on many levels and your great friendship. Yep. So, Gary's not going to drink tea. He's going to drink water. He's going to hydrate well. So, he'll be with us. So, I asked you about some procedural aspects of your practice, but also understanding how to integrate them into a busy private practice and how to make sure it functions well. So one of the things that we've heard so much about, and you see so many different articles, and I started to feel like I don't do these particular procedures. People were throwing the mud at the wall, so to speak, and looking at something that was going to stick. And I kept seeing PRP, platelet-rich plasma, showing up in the literature. And I know that you do a lot of this in your practice. So can you talk about why you utilize that in your practice and maybe go through some of the background on the mechanism of action, what it actually does, and then how you actually do the procedures? Right?
Sure. I think, PRP has been a cornerstone of my practice for well over a decade now. And, in its early infancy in the United States, it was used in Europe earlier and other parts of the world. But when it came to US, it was kind of one of those things that we weren't sure if it was going to work. In fact, I'll tell you a story. I gave a talk on treating androgenetic alopecia with PRP at the Academy. And this is a long time. This is probably about a decade ago, maybe longer. And in my reviews, people called me a snake oil salesman, saying it doesn't work, you're giving people false hope. But now it's clear in multiple studies, there have been innumerable number of studies that show that it does work for androgenetic alopecia, and it can also work for conditions like telogen effluvium. I also utilize it for alopecia areata and for scarring types of alopecia because PRP is anti-inflammatory. But I think if we just take a step back and think about PRP in general, PRP itself is not specific for hair loss. It is a regenerative treatment. Essentially, our body has the potential to regenerate any tissue where PRP is injected. So I'll give you an example. I tore my rotator cuff. I had an injection with PRP and stem cells a number of years ago. Better than surgical outcome I would have had. So I use PRP not only for hair loss, but for other aesthetic procedures, sometimes just as mesotherapy, meaning just injecting it into the tissue, sometimes with microneedling, sometimes after laser, sometimes after other procedures, because I think it makes other procedures work better.
So
And
you
that's
say
how,
sometimes. You say sometimes. So what's going through the mind of Gary Goldenberg when he's deciding sometimes, but other times he's not? So what leads you to want to utilize it in a specific situation?
if it was up to me, I would use it in conjunction with every single cosmetic procedure that I do. It's an issue, if we're being totally transparent, it's an issue of affordability because it is, it's out of pocket. It's a cosmetic treatment. So some patients want to do it and can do it, and some patients just say, "Look, this is my limit. We've reached it, and that's it." And that's totally okay. So I think from that perspective, I think it's basically a financial decision that a patient makes. Now, there's some procedures where I really want to do it, so I offered it at cost, believe it or not, at my cost, because I think that it's going to enhance that procedure so much. And but
Gary, let me just say, I'm not surprised because you're a mensch too. Mark Lebow's not the only mensch in New York City. Gary Goldenberg's a mensch.
thank you,
So,
Jim.
so, so I know you have a very nice graphic that goes through the mechanism of action and some of the supporting evidence for androgenetic alopecia, I believe for telogen effluvium, and maybe some other areas. So can we talk through that?
Sure. So I think that the MOA, the mechanism of action of how PRP specifically works for hair loss, has gone through a gamut of different hypotheses, and it's probable that all of them are correct, and it's really a combination of all of these things. So we know that it releases growth factors. That's what PRP has. It has a lot of growth factors like VEGF, for example, or EGF or IGF-1. And these do several things. They can stimulate dormant hair follicles to start growing again. They increase vascularity. Something like VEGF will increase vascularity in the area. So more vascularity, more nutrition, better growth, supporting hair follicles or inducing those that are in the dormant phase to grow. And then it actually promotes papillae cell proliferation to reverse the miniaturization. So you're essentially inducing the stem cells within the hair follicles to start firing again. But when you put all of these things together, what's the clinical effect? The clinical effect of PRP is that it prolongs the anagen phase of hair follicles. So what does that mean? If more of your hair follicles are in the anagen phase for longer, you have more hair on your scalp. It is not a permanent solution. I tell patients it's like going to the gym. When you go to the gym, everything looks fine. You stop going to the gym, you either gain or lose weight, whatever your body type is. Or if that doesn't translate, it's like a diabetic getting insulin. When they're getting their insulin, their sugar's fine. The minute they stop, it goes back to baseline. It's sort of like that because, Jim, if I'm sure if you see patients with hair loss, you offer them a treatment, the first question they're going to ask is what happens when I stop doing the treatment? Well, when you stop doing your treatment, you go back to your normal baseline. The genetics that you have take over and your hair starts thinning again. And that's basically it. So you have a treatment phase and then you have a maintenance phase, which is what I do for patients with PRP. With telogen effluvium, you can bring the hair back a little bit faster. Sometimes I'll do it to prevent it. Like if a patient had TE after pregnancy, the first baby, we'll actually start injecting them in third trimester to try to prevent it with their subsequent pregnancies.
And it's safe to do during pregnancy?
Well, it's their own blood. So it'd be hard to convince a jury of our peers that the kid doesn't go to Harvard because you did a PRP treatment in the third trimester. I think it's pretty safe, you know?
So
that's
talk about how it's actually formulated. You mentioned their own blood. So what you actually drawing the blood and mixing it from that? Or
Yeah, so I buy these kits that have a separator that separates red and white cells from plasma, and then the plasma gets separated into platelet poor and platelet rich. And there's some controversy of whether or not you need to use both, or you just the rich or just the poor. The evidence hasn't completely elucidated that, but I tend to inject the very rich plasma into the areas that are the most problematic, and then if there's anything left over, we'll inject it in other areas as well. But essentially, you're drawing the patient's blood, you're spinning it down with a specific separator tube, and then my nurse prepares it. She draws it from the separator tube into syringes, and I go and inject it, which we'll see.
So when you're evaluating the patient, are there any signals that tell you maybe this is not the best patient to do this on, either through the conversation or the physical exam?
If somebody comes in and they're a cue ball, this treatment is not for them. So the thing that I always drive home with patients is the earlier you start the procedure, the better you're going to be, because the more dormant follicles, the more miniaturized follicles you have, the best I can wake those up, quote unquote, and let them and get them to start growing again. And the more follicles you have, the better I can support them so they're not miniaturizing and disappearing. Because remember, and I think of this as, in terms of dermatopathology. If you remember from DermPath, a cross section of a scalp with androgenetic alopecia, you have all these follicles that are so small essentially that they have a divergent pathway. They can either become permanently extinct or they can start growing again. Once the follicles are gone, they're gone. So an ideal patient is somebody who is early enough in their process of alopecia, of androgenetic alopecia, that they have enough follicles to actually make a clinical difference.
Okay. Right.
So
Are there
that's
any
really
are there
key.
any medical contraindications that if the patient has a history of a specific situation, you either don't do it or you're more cautious?
If somebody had a melanoma or an aggressive skin cancer on the scalp, you don't want to put something that's pro-growth in that area. That's really the only contraindication that I utilize in my practice. And look, over the past decade plus, I've treated, over 1,000 patients, more or less, or done 1,000 or more, well over 1,000 procedures with PRP, and thankfully I have not had an issue.
So before we go on to the videos, is there anything more you want to say about the background of PRP?
Look, I think if you're practicing dermatology today, and you're not utilizing this treatment, if you have if you have the patient population, if you see a lot of aesthetic patients or you see a lot of hair loss patients, I really think you're doing your patients a disservice. I think this is a very safe, it's a very effective treatment. It's a bit painful for the patient, but it's quick, as we'll see in the videos.
So do you do any kind of anesthetic prep topically, or you'll probably be getting to that, or anything else as far as what the aftercare? What about when the procedure's done?
Yeah, aftercare, some patients will get a headache because we're injecting them with about, on average, 7 to 10 cc's of fluid into their scalp. Scalps are pretty tight, especially in men. So sometimes they'll get like a pressure headache. Otherwise, it's what I call a lunchtime procedure. They can pop in during lunch, get it done, and go back to the office.
Well, yeah, I'd like to go through how you integrate the procedure when we do the videos. Are you ready for the
Sure.
videos, Gary? Okay, so what are we looking at here, Dr. Goldenberg?
So this is a patient I've been treating for well over a decade for hair loss. And she has a typical, what I see now is a typical female pattern. We used to say that women never lost their hairline and just kind of thin on the crown. I think that's complete. I was going to say something inappropriate. I think it's completely untrue, Jim. The Philly was gonna come out of me for a second there.
So,
I think most.
but that's the syringe that has the
Correct.
yellow fluid in, and that's the
Correct.
PRP.
That's the
Now, what is
PRP.
that device that has multiple needles on it?
Sure. So that's a device called Mesoram. I imported from Germany, and it has seven needles as an attachment, and it just makes the procedure go faster because it's not the same number of sticks. I've actually sort of shied away from doing as much of this now because it's getting more and more difficult to import in the United States. So now I'm mostly just using a 30 gauge needle, which we'll also see. But basically, this is it's an intradermal injection. The needles go down to about the dermal subcutaneous junction, which is where most hair follicles are going to live. And I'm just basically making a grid, and I'm injecting PRP in that way.
And how
And
much volume are you injecting each time you introduce the needles in a certain location?
yeah, I used to kind of measure it out a half a c, maybe zero point 0.5 cc's or maybe a little bit more. And now, because I've done it so many times, I basically go by feel. If it's easy to inject, if the area is receptive, I'll put a little bit more. If it's not receptive, I'll put a little bit less. But essentially, think about the area that you're treating. If you're treating a wide area, you have about 7 to 10 cc's. You want to just kind of spread it where you make a grid. And you'll never be able to convince me that it doesn't diffuse underneath the scalp because I know that it does. So we try to, I try to focus on areas where most patients have an issue. In women now, I think it's bitemporal. Believe it or not, a lot of women I'm seeing a lot more receding hairlines as opposed to just crown thinning. So we're just making small injections into the areas that we want to treat, and then it diffuses under the scalp into essentially all the other areas.
So there's no local anesthesia injected. There's no topical. They have to sort of grin and bear it. Do some of them get like diazepam or some sedative before?
Yeah, well, no. So I use, look, there's some patients who don't want anything. They're just fine with it because it only takes, let's say 3 to 5 minutes tops.
Okay.
Some patients are very pain averse, so they want everything. So I have a device called Pronox, which is nitrous gas and oxygen in a 50-50 combination. So, I tell patients it's like getting into a fist fight after you've had a few martinis. You still feel it, you just don't care as much, and that's basically the feeling. They feel like they're high in the sky, so they still feel the injections. They just don't care as much about it.
I
So
remember as a kid, I used to love going to the dentist because they were like, "Hey, this was great." The dentist was using stuff like that. That was a early introduction. But can they drive home after that? Can
yeah,
they
it
drive
goes
themselves?
away absolutely. I make him. We make him an espresso, and 15 minutes later, it's very short lived. Feeling. And then some patients I use a device called Target Cool, which is a freezing device. So I think we'll see that as well, and that
Let's go
freezes the
through. Yeah,
scalp.
we'll move through some of the videos. I'll have you
Let's
walk
do
through
that.
it.
So here, this is one that where we use a Target Cool device. So essentially, I'm freezing the scalp to a certain temperature, -2 degrees here. So again, it just kind of takes the edge off of the injection as we're injecting them. And I think that's effective for some patients. Some patients will just give them an ice pack to hold before the injection, just to kind of numb the scalp. But to be honest with you, most of my patients now, because they've done it so many times, they just want to go for it and just get it over with.
And this takes the total procedure will take you 5, 10 minutes at most.
5 minutes at most.
Oh
At
wow.
most.
Okay.
The longest part, believe it or not, the longest part for me is the counseling, that first visit. You got to explain everything, the treatment protocol, what they're going to do, what it's going to feel like. They come in, my assistant goes in, draws their blood. It takes 10 or 15 minutes on average to prepare. And then, I'm in and out in 5 minutes.
Okay. And so after they leave, what about their activities? If they work out a lot or, they don't wash their hair that day or rub the scalp or anything specific like that?
I am pretty relaxed about what they do afterwards. They can do anything they want. They can go to the gym. A lot of my patients, my female patients, they'll go get their hair done after the appointment
Wow.
because, it kind of makes it a little bit messy. I mess up their hair. They may not be that happy with that. So they go from me to the hairdresser. And honestly, once it's in that dermal subcutaneous space, there's not a lot that you can do to really make it, to make it not work.
Once it's in, and
It's
it's
in.
where it needs to be.
That's right. And you see, the procedure is pretty simple. It's essentially just it's a intradermal injection. It's something that most dermatologists do 100 times a day. It's no different than injecting anything else. You
But
do have to. Go
I'm
ahead.
I'm I'm just thinking to myself, this is Jim Del Rosso talking about Jim Del Rosso. I would lose track of where I just injected. Do you have a sequence you follow? And go, oh, did I
Yes.
inject there already?
And,
Because
and and
obviously they
honestly,
have the
Jim,
hair.
yeah, you wouldn't lose track because you could feel it because you're going to see some fullness. You're going to feel some fullness in that area, and you might see some pinpoint bleeding, which usually is minimal, but you might see some pinpoint bleeding. So I think you would do very well with it.
So now we're going to go on to the next video. I believe you have where you use a needle and not that multiple injection
Right.
device, right?
So this is a simple 30 gauge needle, and if I want to be more precise, or if a patient's more experienced, so they're okay with more needle sticks, I'm using just a plain old 30 gauge needle, and you can see I'm injecting somewhere between a half a cc and maybe a cc in the area. This is another female patient with the receding hairline, so we're focusing our efforts on the frontal scalp, and I'm essentially just making a grid. I'm injecting somewhere around a centimeter apart from each injection. So we're making a grid with the PRP, trying to slow down that process of recession and trying to induce some follicular growth there as well. Again, a pretty simple subdermal or intradermal injection into the area that's problematic.
So you might only treat a region, like if it's mostly frontal, you're not doing the rest of the scalp unless you saw actual thinning there. Then,
Correct.
right.
Correct. Because, as you remember from the classification of androgenetic alopecia, sometimes it starts in the front, sometimes it starts in the back, sometimes they're concurrent. So you need to use your clinical exam and your clinical acumen to decide exactly where to inject. And look, a lot of times I'll ask the patients, I'll say, look, what's the area? Because it's a limited supply that we can inject. What's the area that bothers you the most? And whatever that area is where we're going to go and inject.
Let's keep bringing up the additional uh, videos so Gary can talk through any differences from one to the other.
Yeah, so here's another one where we're using a simple 30 gauge needle and we're using the cooling device for analgesia. Here, the patient has some thinning on the crown itself, so you can see I'm injecting onto the crown, so frontal and crown as well. You can see where the part is; it's a little bit wider than the other areas, and you can see the patient is talking. They're quite comfortable. It's really not a big deal to do this procedure, and the whole thing really doesn't take more than 5 minutes.
What's
So
the
I think
youngest age you've ever treated a patient with PRP, would you
for
say?
androgenetic, I have a patient who I started seeing at 15. He had a hormonal imbalance that required him to take some growth hormone, and the father was convinced that's what caused his androgenetic alopecia. Although the father lost his hair at 20 some years old, so probably more genetics than anything else. So I've been treating this patient now for about 5 years, and he's in college. And I think he told me that his goal is to get married, and then he's not going to care as much. So we'll see what happens, as he moves through life. But 15 is the youngest patient that I've treated, and then my oldest patient's probably in her mid 80s, I would say,
Wow.
and
Yeah.
still cares about how she looks. So
Yep.
it's a great thing.
Yep. Upper East Side. Upper East Side.
Well,
Right?
the thing about this procedure, Jim, is that I see patients from everywhere. People with hair loss, especially women, it's an emergency. And I see women, both men and women, but more women than men from all over the world to come and see me for PRP, for stem cells, for exosomes. So I've been very fortunate in that way to build a practice that's really national and international.
So that made me think of something. You're getting people from all over the world, so that's primarily word of mouth, or how much marketing, especially in the beginning, did you do, or do you just treat patients and they tell other patients when they have success?
Yeah, look, I think that like most practices, my best patients come from other best patients, their friends, colleagues, coworkers, family members, etc. I love social media, so I have a million videos of injecting patients and myself on my social. So I think that drives it as well. But look, I've been very fortunate to have really nice patients who, if they're happy, they'll send other patients to come and see me.
So you have a consent that they allow you to use their videos that they sign and they know they might be on social media, or some of them they're
Yes,
not going to be easily identifiable, but you'd be surprised. So that you work that into your prep with the patient ahead of time.
yes.
Right.
It,
Most people
it,
probably are okay. Yeah, go for it.
you know
They
what?
like helping others.
Aside from having that in my consent, I will verbally ask them. If we're recording a video, before we record the video, I'll verbally ask them, look, I may use this for social media, for lectures, to show other patients. Are you okay with that? And especially with this treatment, because it's not easy to identify somebody, most people are gracious. And if you ask them, they'll say, okay. And look, I'm not just going to ask any patient. It's usually going to be somebody who I've known for a long time, have a relationship with them. They know me and they trust me not to, to do something that's not kosher.
So let's go to the next video. I think this is the last one utilizing a needle for PRP, and then we'll go on to the next topic. So what's the presentation here? This looks different. The
Yeah,
syringe
so
looks smaller.
it's a smaller
Okay.
syringe. So what's happened is because as a lot of us, I developed a little tendonitis in my injecting hand. So the 10 cc syringe tends to have a little bit more back pressure. So I've now switched to a 3 cc syringe because it's a bit easier to inject. So that's
Yeah.
basically it. Otherwise, everything else is the same. It's the same
Yeah.
procedure, same technique, same counseling, same
So
analgesia.
what's the cooling device, and where can people get that?
Yeah, so this is a device called Target Cool, no conflict of interest. It's a device that was launched in U.S. a few years ago. Essentially, it freezes the scalp to or skin to a temperature that you could set. Some colleagues may choose just to use straight up ice because obviously it's available and inexpensive. Some may have cooling devices they use for their laser procedures, which could work as well. Some people use a vibration device that you would put on the scalp to kind of confuse the neurological system from feeling pain because vibration and pain are transferred. The signal is transferred to the brain by the same nerve fibers. So there are multiple ways to make the patients comfortable while doing this procedure. And look, I've treated people from all over the world, from all types of walks of life. And I've never had a patient who I've not been able to get through a procedure. Even if they
So
say, ouch, you could still do it.
so what was the presentation in this patient where you're selecting where you're injecting right now?
So this patient had a combination of androgenetic alopecia that was unmasked by telogen effluvium, which probably is one of the most common presentations I see in women, where they get telogen effluvium, the hair starts shedding, and it unmasks androgenetic alopecia. I actually learned that at very start of my residency with Amy McMichael, who was a hair loss specialist at Wake Forest. And we see that a lot where patients, especially female patients, will get telogen. It will unmask their androgenetic, and once they have it, they have it. So, this is a great treatment because you can kind of get both shots on goal here.
So what about differences in different races or different skin colors or skin types in terms of concerns or even response, right?
No difference that I've seen. I think PRP is safe in all skin types. It's anti-inflammatory. So I think some patients may have a more of an inflammatory component to their androgenetic alopecia. They may have something else, maybe seborrhea or scalp psoriasis, something with more inflammation, where I think PRP is highly effective because we know that it has anti-inflammatory properties.
So if they do have an eruption on the scalp, seborrheic dermatitis or psoriasis, for example, uh, do you have to get that clear before you would treat them, or do you work through that actual condition?
Not necessarily. If they're clear, obviously it's better. But if they have, let's say they have a little seborrhea with some scaling and redness, oh, I don't mind it. If they have really bad plaque psoriasis on the scalp with thick plaques, and it's in an area where I want to treat them, I might inject them with a steroid first, bring them back in a few weeks, and then inject them with PRP or do exosomes.
So, Gary, I'm going to admit something publicly. I do not understand or know enough about exosomes. And I know you've been getting involved with exosomes and you have some procedures with delivering exosomes. So, can you educate Jim Del Rosso? What is an exosome and are there different types? Do they apply to different situations? So, help me out here.
So I think maybe we should bring up that chart that I have that goes through the MOA for using exosomes for hair loss. And while we do that, you have to take a step back. So, if you look at regenerative medicine and the way it's been used in dermatology and beyond, I think most people started with stem cells. Most people started with pluripotent stem cells. The majority of them came from either bone marrow or hair follicles or umbilical cords. of babies being born by C-section. So that's where I started. I started using stem cells in my practice about, I would say, 8-9 years ago. And we started using umbilical cord stem cells, which were really not specific. There was a lot of variability, Jim, because the health of the cells depended on the health of the donor. So I went as far as doing liposuction and taking adipose tissue, filtering it out and making adipose stem cells. Again, the stem cell health depended on the health of the donor. And then we started hearing sort of downstream about exosomes. And I first heard about exosomes at a lecture on burns. And essentially an exosome is nothing more than a outpouching of a cell that contains something inside, okay? So when one cell is well and one cell is sick, the cell that's well will send an exosome with things to repair the cell that's not well to the ill cell. It's sort of the way that the cells repair each other, because
So
exosomes,
this is happening
it's happening in our
physiologically
bodies. Physiologically,
as we
it's happening
speak.
as we speak.
Wow,
So,
interesting.
so the first exosomes that I used, again, were from birth tissue, from placental tissue, from umbilical cords, and they're labs that will buy or get. They don't buy. They actually get donations of that birth tissue from, C-section deliveries of healthy mothers, and they'll extract exosomes from that birth tissue. Now, here's the part that sometimes gets confusing, and I see this all the time. Stem cells and exosomes are not FDA approved to be used for humans, period. Okay? So what you'll see sometimes is a lab saying that we have an FDA-approved product. What they really mean is that the lab itself, because the lab is handling human tissue, the lab has to go through a regulatory process of approving the lab to manufacture and make these cells. But the product that they manufacture and sell is not FDA approved. There are no FDA approved human stem cells or exosomes, period.
It's interesting
Okay?
you say that, because it's the same with some of the compounding pharmacies saying they're FDA approved, and people assume that their compounded products are FDA approved. They're not. That pharmacy is FDA approved to be able to
Correct.
compound, and there's a big
Correct.
difference, and people will confuse that. So I think that's a very important distinction. Thank you for pointing
Well,
that
I'll
out.
tell you, the FDA had a quiet period, as they call it, where they didn't really enforce the rules. And that quiet period has been over for a few years. So some of us that were using a lot of human tissue, stem cells, exosomes, got letters from the FDA saying, hey, you're using a product that does not have an approval, and it's technically a biologic product that doesn't have an approval. It doesn't mean that you can't do it. It's just to make sure that you understand what you're doing. And look, when I used human exosomes and human stem cells, I told patients flat out, look, this is not an FDA approved product. It's not FDA approved for anything. It's considered experimental. I think it's safe. I think it's okay to use it, but it does not have that stamp of approval. So that's a very important distinction. So I just to put this out there, I've graduated from using the human exosomes to now using plant-based exosomes that are approved as a topical delivery. So we'll see one of the videos with a topical delivery system. So as far as the MOA, the mechanism of action, it's irrelevant to whether it's human tissue or it's plant tissue or synthetic tissue. So the mechanism of action is similar to in AGA and TE. And again, these are chock full of growth factors. We know for a fact that stem cells and exosomes stimulate the beta-catenin pathway. And there's some actual test tube evidence that maybe you're actually making new hair follicles. Now, I don't say that to patients because I never want to overpromise and underdeliver, especially if there are no human studies. But there's some evidence that potentially through the beta-catenin pathway, we may be upregulating follicular growth and follicular activation. And then you downregulate some inflammatory and pro-apoptosis molecule as well. You have DPC proliferation and migration, which helps with follicle support and formation. Again, angiogenesis is an important part of the story. And then we have the shift, as we did with PRP, from telogen to anagen. So if you take all of these things together, how does it work? Well, it again prolongs the anagen phase, so you have more hair on your scalp for a period of time, call it 6 months or so. And then you may be able to bring back some of the follicles that are miniaturized, and maybe, just maybe, the hope is that maybe you are promoting formation of new follicles. But again, I don't tell patients that because I'm not 100% certain that's actually happening.
So you're gaining the density. You have to maintain it, like you said with the
Correct.
PRP. It's not something you do once and it's going to last forever. So you have androgenetic alopecia and telogen effluvium on the graphic, and we've already walked through it with PRP. How are you deciding whether to use PRP or to deliver exosomes for the same diagnoses, picking one versus the other?
So PRP is the basis of what I do. PRP forms a lattice, and again, a lot of that comes from the burn literature. PRP forms a lattice. It's like a foundation of a house. That's what I tell patients. So everyone gets PRP. Now, if it was up to me, I would use exosomes for every patient at every visit. But to be quite honest, it's a financial decision. Some patients can do it, some patients can't do it. And how often we use it, again, for most people is a financial decision.
So are they getting PRP and then shifting over to exosomes, or they continue to get both?
They can get both together. And in my preference is always to do both at the same visit. Now, by FDA guidance, you can't mix them. So I can't mix PRP and stem cells together and inject both at the same time.
In the same syringe, you mean, by
Correct.
mixing? Right.
Correct. But it doesn't mean that I can't do them in sequence. Do exosomes and then inject with PRP, or do PRP and then do exosomes. So that's what I usually do. I usually use them in sequence.
So it's video time, Gary. Let it roll.
Let's do it.
Right? So you still have that cooling device.
Yep. So this is human exosomes, and because they can be injected. And this patient mostly was concerned about the frontal area of the scalp, the recession. And to be quite honest with you, I actually think that exosomes with PRP work much better than PRP alone, especially for the bitemporal and frontal area in androgenetic alopecia. I've had a lot more success combining those two modalities in this location. I think that's the hardest area to treat. It's the first area that goes away, and it's the hardest area to bring back. So again, I'm just essentially delivering the product into the dermal subcutaneous junction. It's an intradermal or subdermal injection. We want to target where the hair follicles live, so we're putting it in there. And again, I'm just making a grid of the areas that I want to treat, and we're just gently injecting. This is a 30 gauge needle into the scalp. And I think this patient had a PRP treatment a few minutes before recording this video. So now we're just layering the exosomes on top. Depending on the product, the injection is usually anywhere between 1 and 3 cc's. So depending on how much product I have to inject, I kind of just budget it for the area that I want to treat. Again, fairly simple injection technique, something that you do in your office a million times a day, and you've done a million times before.
So I'm noticing that the solution is clear. The PRP had a yellow color to it, right?
Yeah, PRP is always yellow. The exosomes or stem cells, the color will depend on the manufacturing lab. Some labs may put a dye to make it easier to see. Some labs, it's clear. Again, I've used many different manufacturers for the human exosomes specifically. And what I've noticed is, a lot of them will have some difference in consistency. I've gone as far as using lyophilized powder exosomes where I mix it with saline, which I did like when it was available because I could, put more or less saline to get the right amount of cc's that I would need to cover an area. Some came in a pre-filled syringe. there's a lot of variability based on the manufacturer.
How do you store them? Do they have to be refrigerated or?
Yeah, so one of the issues with the human product is it has to be in a cold chain. So I have a fridge that goes to minus 180. It's like you would use, Jim, in a clinical trial setting.
Right.
It's that kind of a refrigerator. So it's pretty cold. They're frozen, and we kind of thaw them out for a couple minutes before we inject them.
Let's get the next video up so we can. Now, is it the same lack of restrictions? They could wash their hair, they can do whatever they
Correct.
want
Correct.
afterwards, so it's no
Correct.
different than the PRP. Okay.
Correct. So this is the latest product that I've been using for about a year now. This is plant-based exosomes. So they're a product of three different plant cultures mixed together, and pretty compelling basic science data showing anti-inflammatory and regenerative function. So I use this product either with microneedling, which is what we're going to see here. So I'll microneedle the scalp first. And now I've moved to using an ultrasound to deliver those cells as well. That's the newest thing that we've been using. And I don't have a video of that yet because it's
So
brand new. But
what's happening here?
so I'm microneedling this
Device.
patient's scalp.
Okay.
This is a microneedling device. And we are going to a depth of 0.5 millimeters. So very, very shallow. It's not very deep at all. And I've done this to myself an innumerable number of times. It feels like a tickle more than pain because it's so superficial.
So
It's a half a millimeter, Jim.
is the microneedling happening before and then the exosomes are applied, or is it mixed in that device together?
No, so we're microneedling first, then I'm applying the exosomes topically, and then I will microneedle again. So microneedling does two things. There's actually pretty compelling evidence that microneedling itself can induce anagen, can take a hair follicle from telogen to anagen. So we're harnessing that as well. So we're microneedling. So we just did the microneedling at a half a millimeter. And then what you'll see is I'll be applying the exosomes topically, and then I will be microneedling once more just to kind of try to push them in. So you're making little channels in the scalp by microneedling. The exosomes get absorbed, and then just for good measure, we do it one more time.
Yeah.
And this
So,
takes about 5 to 10 minutes, the whole
so
procedure.
the patients just feel little pinches. It's not like
It's
not
more
not
like a
not
tickle.
painful, right?
It's not painful. It's more like a tickle. Now, the second time I microneedle, if they can take it, I'll go to 0.75 millimeters to make sure that I'm pushing the exosomes in. That tends to be a little bit more pinchy, I would say. So if they can do it, great. If they can't do it, I'll do the half a millimeter. You see, this patient is completely comfortable. We're having a conversation.
So
So I've done the first microneedling, and now I'm going to be applying the exosomes. It's essentially a pre-filled syringe that I purchase, and putting it on the scalp, and I'm rubbing it in. These are lipophilic, so they like to go into the hair follicles. They get right through the scalp, and then the microneedling really helps.
So when you were using that microneedling device, you were moving it so fast that it was able to give those individual zero point 0.5, 0.75 depth
Yes.
injections so quickly in all those areas where you're moving
Well,
it?
the device itself is like a rotor-rooter, so it's oscillating at a very high speed going like this. So I'm moving it. As I'm moving it, it's basically making little holes in the scalp. It's
Wow.
the same kind of device I would use for the skin for microneedling. So I do this for the skin as well for rejuvenation. Different product, but similar technique.
I'm picturing those sewing machines that were rapid fire, right?
It's
Going
basically
real
what it
quick.
is.
Yeah.
It's exactly what it
Right.
is.
I
Yeah.
don't know if
So
I don't know how many people remember Singer sewing machines, but they were rapid fire, right?
yeah, maybe some people in our generation, Jim,
Yeah,
are older.
yeah, yeah.
But essentially, I'm just basically putting the product topically. So this product is a topical product, so it doesn't have the same regulatory pathway as human exosomes that are injectable. So I'm acting within the confines of what I'm allowed to do from a regulatory perspective, but I'm also doing delivering a treatment that's highly safe, high safety and high efficacy.
So I have a couple of other questions, and then we'll let you go because you probably have some patients waiting to get this procedure as we speak, or one of these procedures, or one of the other incredible things that you do, Gary.
You're
Uh,
very kind, Jim.
so, with each of these, with PRP or with the exosomes that are being delivered in their scalp, when can they expect to see the looking in the mirror to see a visible difference? Because a lot of people, they're going to check the next day, Dr. Goldenberg, nothing's happening. So what's the realistic expectation with that?
Well, if you remember that our follicles are on a 3 to 6 month cycle, it takes 3 to 6 months to see the difference. So, what I tell patients is that in the first 3 months of treatment, while they're going through the treatment, what they may notice is the hair is not shedding as much as it used to. And that usually happens after treatments 1 or 2. And then I always bring them back 6 months from the time that we started. And we take photographs and we see how well the treatment worked. And look, it doesn't work for everybody. There are no treatments that work for every single patient. If they had a good result, which means either they haven't lost any hair or they've gotten more hair, because look, not progressing in 6 months for some patients is good enough,
Right.
because they just
Right.
want to stay where they are. If that's the position where they are, then we put them on a maintenance therapy.
So
If
you
they say, look, I
judge,
don't see any difference, then we offer them something else.
so you will judge whether it's going to work for them or not based on that initial procedure, or might it be, hey, give it one more shot? I mean, I'm thinking about it realistically
Sure. So
when you're
the
pulling the
way
plug.
that so this is what I do. This is my algorithm. They do 3 treatments 1 month apart to begin with. So they come in. Let's say you come in today to see me. We do microneedling with exosomes and PRP. You'll come back in a month. We'll either do microneedling alone or microneedling with exosomes again. You come back another month. We'll either do PRP alone or PRP with exosomes. Okay, those are your 3 treatments. Then we wait 3 months and see where you are. If you're a success, which I think is about, I'd say 85, 90%, we put you in a maintenance therapy. Maintenance for me is one of 2 treatments. We're either doing PRP once a quarter and exosomes once a year, or we're doing PRP and exosomes twice a year. I give patients a choice, whatever's better for them. Okay, scheduling wise, pain tolerance wise, etc. And then once they're in a maintenance phase, we just keep going with that maintenance phase. And
So,
some
so I'm
Go ahead.
sorry. Go ahead. No,
No, please go ahead.
no.
You go first.
So I wanted to ask you, are some of these patients on oral finasteride or oral minoxidil throughout doing this, or what's this, or might you start that later? I mean, they probably come in different ways. They're coming from other people, and they're on certain therapies. So how do you integrate the medical therapies with the procedures?
So look, I think with hair loss, especially androgenetic, you got to throw everything in the kitchen sink at it, because once those follicles are extinct, they're not coming back. So we do a lot of different things aside from this. We'll do red light therapy. We'll do topicals like minoxidil, and sometimes I'll add topical finasteride or topical spironolactone. For some women who also have bad acne that's hormonal, we'll add spironolactone. Um, I tend not to write minoxidil from the beginning, because we know that minoxidil oftentimes will cause telogen effluvium.
Right.
So we want to stabilize their hair follicles before we add minoxidil. But I do have a number of patients on minoxidil. It's usually 1.25 milligrams for women, 2.5 milligrams for men. If that can tolerate it, not everyone can tolerate it. As far as finasteride goes, I tend not to prescribe oral finasteride. I think there's, I used to have hundreds of patients on it. Now I have very few, because I think that there's been a lot of new data as far as side effects of finasteride. I think it's still fairly safe, but I just don't feel like we need to take a chance. So I have very few patients on oral finasteride. I'm much more comfortable with topical finasteride.
So, oral finasteride I was on for many years because the first time Jim Del Rosso saw a hair in the bottom of the shower. It was a crisis. You talk about it being an emergency. So I went on finasteride, the 1 milligram, and I did fine. I didn't experience anything negative. I felt it was actually very helpful. But then 15, 20 years later, I was getting nightmares and I didn't feel right. And, I said, could it be after that long? I stopped it. And within a few months, I felt better. But I had read sometimes the effects from finasteride don't go away. And after talking to a couple of other people that do a lot of hair, they said, try it 3 times a week. And I did, and that problem came back. So the re-challenge, I switched to minoxidil 2.5 once a day. And when you talk about the telogen shedding, if I wasn't somewhat aware of that, I would have thought I was going to lose all my hair. It's not just a little bit of shedding. It could be
It's
a
shedding.
very,
It's
very
real shedding.
significant shedding. Yep.
Yeah.
And so that's something you have to warn patients about for sure. Right.
Yeah, and I tell everybody that might happen, but if somebody comes in with telogen to begin with and androgenetic, I think, the way I always think about it is I want to stabilize their follicles first. Once they're stabilized with these other regenerative procedures, then we can add oral minoxidil if it's necessary.
Yeah.
The biggest issue that I face is unwanted hair growth in women. That's really the biggest issue with oral minoxidil. Even on a 1.25 milligrams, some women are very, very sensitive to it. Not to generalize, but it tends to be the bigger issue for female patients and male patients.
So, Gary, I'll ask you, you've talked a lot about a lot of things with hair loss. Is there any final pearl that you've not said that you want to make sure that I understand and our listeners understand? Our viewers, they're seeing your face right now.
That's right. Look, I think for me, the most important thing, and I ask patients this flat out, if you're going to care about losing your hair later, the time to act is now. If you are just starting to lose your hair and you think you'll care if you lose 50% of it over the next 5 years, the time to do something about it is now. It's not time to wait and see what happens, because we know what happens, especially with androgenetic alopecia. It's chronic, it's progressive, and eventually your hair will thin or will be completely gone. So I think the most important thing for patients is to make sure that they get their treatment as early as possible at the earliest stage of hair loss, because the earlier they come in and see us, the better they'll do down the road.
Makes a lot of sense. Gary, thanks so much for your time, your expertise, sharing of these videos. Thank you to the patients that allowed you to use this information. I learned a lot today, so I'm sure other people did too. Thanks so much for your time.
Thank you, Jim. It's always great to be with you, and I love talking to you about dermatology and different treatments. So it's a real honor and pleasure to be here, and I appreciate everybody tuning in and watching.
Give my regards to your beautiful wife, Christina, and of course to your kids. I love your kids. These kids are very special kids. Have a great day.
Thank you, Jim. Bye-bye. Bye, everyone.